and the
Yeah.
result of a clean catch urine on dipstick that is given to you.
Okay.
Okay, so the first
Dr.
question.
Tahir, any indication we do suprapubic aspiration for children?
Yeah, suprapubic usually we do when you cannot do a clean catch. I mean, the child is very much young, and you are highly suspecting that there is a UTI.
UTI. Okay.
Yeah, and I mean the bag will not be a good thing to do UTI. They say about the urine bag that if that is negative, so okay, that it means that there is no UTI. But if that is positive, then you have to do something else. I mean, you should not treat it with the positive urine bag. If the urine is positive for infection, so then you have to do either a clean catch or something else. This is just to rule out thing, the urine bag. So
Okay.
so usually we should not be concentrating on that. Okay, so this is the data given to you. So the first thing is interpret the urine dipstick result. So what do you think? What is that? Leukocyte 3 positive, blood is trace, and everything rest negative. Okay, so I'm your examiner. So what do you think? What will be the result?
Yeah. Interpret the urine dipstick. See, leukocyte positive, blood trace, protein negative, nitrite negative, and urobilinogen, but the child is symptomatic. Okay, painful micturition, but nitrite is more sensitive than the leukocyte.
Exactly.
Okay, so so this case is a suspicious case of UTI. It is not proven. If it is reversed, like nitrite is positive, but leukocyte is negative, then definite case. It's a definite case of UTI. Then we will send culture sensitivity. But now we have to repeat the urine sample with culture sensitivity.
Yeah. So see, I mean, there are two things positive here. Blood is positive, although trace, but positive, and leukocyte.
Positive.
So I think that there is some evidence of inflammation, but it doesn't reflect that it is in the urinary tract or it is outside the urinary tract. Why? Because the vulva is also red. So it means this WBC might be coming from this perivulvar region.
Yes, vulvovaginitis. Vulvovaginitis.
So as you said, like until the nitrite is positive, and if both nitrite and leukocyte is positive, then this is even more strongly suggestive of.
More strong.
Okay, so what is the significance of the result?
Significance is we should rule out vulvovaginitis and we should rule out UTI, both.
Yeah, the same what we discussed. So what is the most likely diagnosis?
So we can take culture, culture swab from the vulva.
Yeah, exactly. So what is the most likely diagnosis for this child?
Vulvovaginitis.
Yeah, exactly.
With complicating UTI.
Yeah.
Or painful micturition due to urethritis.
Yeah. Okay, so how will you manage this child?
So first of all, supportive care, like for pain, we will give paracetamol. And then we will take the child comfortably, and I mean lots of water, plenty of water, and maintain the hygiene of the vulva. Okay, repeated cleaning and moisturizing with some vaginal cream. I don't know, maybe antibiotic cream. We can use fusidic acid here.
Yes.
And we will give, of course, we will send repeat urinary and culture both, and swab from the vulvovagina.
Yeah.
If anything comes, then we will give oral antibiotic. Otherwise, local antibiotic, I think, should be given locally.
Yeah, exactly. Okay, so
and also the advice so that the patient is not having so much pain. So I will tell the mother to give fiber diet so that the child become less constipated, because constipation will aggravate the situation.
Yeah.
Okay,
so let's move toward the first question. So interpret the dipstick. So the urine is strongly positive for leukocyte, weakly positive for blood, and negative for nitrite and protein. So this is the interpretation. Now, what is the significance of the result? So strong positive leukocyte, it means that there is inflammation, but The site is unspecified. Weakly positive for blood means that there is some local inflammation, and negative nitrite means that it is unlikely that this is a UTI. Now, pyuria or leukocytes in the urine are present in children with UTI. However, this can also be a finding with balanitis, vulvovaginitis, and in sterile children, even in the absence of UTI. So, infection of the urinary tract can also occur rarely without pyuria, seen in children in compromised immune system and units. Yeah. So, a positive result for blood in the urine analysis may indicate a UTI. Other causes include nephritis, renal calculi, renal trauma, bleeding disorders. Yeah. So,
Dr. Tahif, until now, we got that leukocyte, that is pyuria.
Yeah.
Okay, pyuria may be a cause of UTI. However, pyuria may also cause by the local infection like balanitis, vulvovaginitis, and febrile children. And I'm telling you, this scenario came in communication scenario in UK in 2019. Okay, the scenario was talk to a teenager about the vulvovaginitis. Same scenario. Okay, yeah. So this scenario is important. Okay, vulvovaginitis. So remember, leukocyte in urine may become positive in UTI, suspicious case of UTI, but there is local infection. But nitrite here in this case was negative. So it is unlikely that it was UTI.
Yeah.
Okay. Okay. So what NICE guideline says, NICE guideline says, just 1 minute, NICE guideline says, infection of the urinary tract occur more rarely without pyuria, seen in children with compromised immune system and units. So remember, UTI, very rare without pus cell, without the WBC. So very rare.
Yeah.
Okay. A positive result for the blood in the urine may indicate UTI. Other causes are same. Vulvovaginitis, like itching, scratching. Okay, suppose there is pinworm infection. In that case also there is vulvovaginitis, and that can cause blood in the urine.
Yeah.
Okay, and this pinworm infection came in exam, history taking of pinworm exam in UK in 2019 or 2020. Pinworm, okay, history of pinworm infection, history from the mother. There was blood mixed urine, you know. So these all topics are very important because we don't practice this thing, right? So a positive blood may indicate UTI, but what are the other causes? Other causes are trauma, itching, local infection, okay? Then calculi. So you have to rule out the familial calculi, that is called familial renal calculus, okay? Then nephritis, like glomerulonephritis. Then other nephritis, like, you know, focal proliferative or mesengeoproliferative, that has blood mixed urine, or bleeding disorder, like especially von Willebrand disease, okay? And a positive nitrite result in the urinalysis is likely to indicate a true urinary tract infection. Yes, nitrite is more sensitive than WBC, but remember that WBC usually present, invariably present with UTI. However, a negative nitrite result on a urine dipstick does not rule out UTI. Tarmane, this is a suspicious case of UTI. So nitrite are the result of bacteria metabolizing protein found in urine. So why the nitrite is produced? It can be a question in the history taking, why the nitrite is produced. Because in history taking, it is around 4-minute or 5-minute discussion. You know, that time the examiner can ask you anything regarding investigation, anything. So why the nitrite is positive? Because the bacteria,
because of bacteria.
Yeah. They metabolize the protein and nitrate, they are the same compound. And therefore, if the urine stays in the bladder for several hours, even normal urine may test positive for nitrite, AIVA. So if there is a bacteria in the bladder, it will anyhow produce nitrite. If you are stuck, it may be helpful to consider the differential diagnosis in this case. Okay. Okay, next. So what are the differential diagnoses of dipstick of urine? See, if leukocyte, this is NICE guideline, okay? This is from this chart taken from the NICE guideline. If leukocyte and nitrite both are positive, you start treatment even without symptom. Even without symptom, you start treatment. Leukocyte negative, but nitrite positive, same, you start treatment even without symptom. Now, leukocyte positive, nitrite negative, don't start treatment. Does not necessarily represent a UTI, but should be correlated with the clinical feature. Now, here, if the patient is symptomatic, like in this child who has vulvovaginitis, this child, leukocyte was positive, but nitrite is negative. In this case, you have to correlate with the clinical feature. And I think before starting treatment, you should send repeat sample and urinary culture, because this is a doubtful case. Okay. Now, leukocyte and nitrite negative, don't start treatment because it is unlikely it is UTI. Okay. Blood positive, hematuria, so rule out nephritis, trauma, pyelonephritis, rule out. If glucose is positive, rule out diabetes mellitus and renal glycosuria or Fanconi syndrome. Rule out this thing. Okay. Protein positive, rule out again, rule out febrile illness. It can be transient proteinuria. And rule out calculus like nephrotic syndrome, sorry, renal cause like nephrotic syndrome or glomerulonephritis, or rule out strenuous exercise. Sometimes strenuous exercise, then febrile illness, then pregnancy, that if the patient has other systemic illness, okay, they can pass urine like SLE, GIA, SOGIA, systemic onset. They can have this proteinuria, transient proteinuria. Okay, sometimes proteinuria can present orthostatic proteinuria due to whole night lying in the bed. In the morning sample, it will be protein. That is orthostatic proteinuria. So rule out, is it physiological proteinuria or is it pathological proteinuria? Usually more than 20 milligram per DL, I think, or something. I forgot. Protein creatinine ratio. You see the protein creatinine ratio. Protein creatinine ratio is less than 0.2, 0.2. This is physiological. Okay. If protein creatinine ratio is more than 0.2, this is not physiological. This is usually pathological. If protein creatinine ratio is more than 2 millimole per millimole, that indicates nephrotic syndrome. Am I right, Dr. Tahir? I forgot actually, but I remember this much, protein creatinine ratio.
What I remember is that the normal is less than 0.2, and if it is more than 2, then this is nephrotic. I don't remember that much.
Okay. Okay. Read next, Dr. Tahir. I think this chart is very important. Okay. And UTI, I'm telling you, UTI you will get invariably in every
very
exam.
Important. Very important. Yeah. So I think the most important thing to remember is that the sensitivity and specificity is 100% for UTI if both nitrite and leukocytes are positive. Then if only nitrite is positive, still you will consider it as a UTI and treat it. But if nitrite is negative and the leukocytes are positive, then it is less likely. Okay, you need a bit more investigation. And if both are negative, so this is not a UTI. Yalla, okay. So what is the most likely diagnosis in this child and what differential needs to be considered? So the urinary dipstick result combined with the clinical picture suggest a vulvovaginitis, and the results are unlikely to be due to a urinary tract infection. Yeah. So the child, consider the data in the light of clinical picture. A clear pass candidate will integrate the urine finding with the presence of dysuria in an afebrile child with normal examination and come to the conclusion of vulvovaginitis as the probable diagnosis. Now, this child has presented with dysuria, which could be symptom of a UTI. However, she is systemically well, without fever, vomiting, abdominal pain, and urine dipstick only shows leukocytes. Therefore, it is unlikely to be a UTI. Another common cause of dysuria is vulval inflammation and irritation. Vulvitis refers to external genital pruritus, a burning sensation, redness, or rash. Vaginitis implies the inflammation of the vagina with discharge, abnormal smell, and bleeding. And common cause of vulvovaginitis include poor hygiene, non-esophageal, non-estrogenized trait, infections like E. coli, Streptococcus pyogenes, Staph aureus, H. influenzae, and fungus like Candida, and worm infestations, as Dr. Manu said. And other rare causes include the foreign bodies and sexual abuse. That is very, very much important. Now, to talk about the pinworm infection is a
So
common
until
type.
now, Dr. Sahil, please summarize until now regarding the vulvovaginitis. What should we
Yes.
do?
Yeah. So, I mean, first of all, if like in this case, you have ruled out the UTI and you suspect that this is a vulvovaginitis, so what you need to do is that they just talk about that what is vulvovaginitis. So they just explain that
Okay.
this is inflammation of the outside and vagina. Then they talked about that the causes, that what can be the causes of vulvovaginitis. So the causes can be a poor hygiene,
Hmm.
uh, infections, which can be bacterial and which can be fungal, most likely, and
Mm-hmm.
worm infestation. So these three are the
Worm
most
infection.
common.
Hmm.
Yeah.
Okay. Mm-hmm.
Now they're taking it one by one. So the worm infestation, especially the pinworm, is a common type of worm infestation that presents with
Bacteria
symptoms
I
in the.
did not say. Bacteria is E. coli, Streptococcus pyogenes,
Yeah,
Staphylococcus aureus.
yeah. I said that H.
Okay.
influenzae. Yeah,
Haemophilus fungal. They
yeah,
ask you this thing, the causes of
yeah,
the mother will ask you, doctor, what bug? Then you have to name the bug. Mother sometimes very much, very much clingy mother. So they will say, what bug? Okay. So E. coli, Streptococcus, Staphylococcus, then if Haemophilus fungus is candida. And worm is which worm? Mainly pinworm, threadworm, and
yeah.
or also hookworm, also like roundworm. They can any worm can cause this thing.
Yes,
Okay, yeah.
the next very important thing is that the worms, they reside in the large bowel and come out to the perineum to lay eggs at night. This is very much important because they can ask you question that I have itching in my front and why, and the worms are usually at the back. So how come they can
Yeah.
cause this? So this is the
Yeah.
thing that they usually come out at night from the large bowel and they lay eggs there, and that's why they can cause itching.
Hmm.
This presents as perennial itching, which is more common at night. Occasionally, the worms may be seen in the stool. Threadworms infection can cause loss of appetite, weight loss, bedwetting, and vulvovaginitis. The
Hmm.
sellotape test, or also called a tape test, is recommended to document a threadworm infestation. This test involves sticking sellotape to the perineum at night, removing it the next morning, and examining it under a microscope for worms or their eggs. Yeah, this is a very important test for threadworm. This is a sort of a sticky material. You just put that at the perineal region, and you keep that at night and remove it the next morning. Uh, Unstick it from the body and just examine it microscopically in the morning to see for the eggs and worms there. A detailed history of associated symptoms, just as perineal pain, pruritus, uh, bad discharge, bad smell discharge, and nocturnal pruritus, will help to guide investigation. Information about the urinary frequency, fever, abdominal pain, diarrhea, and previous UTI must be sought. Information about hygiene measure and possible chemical irritants such as soaps, laundry detergent, swimming pools, or hot tubs must be explored. This is also very much important, Dr. Manna, especially if you are taking history of vulvovaginitis, about the fancy soaps and the detergents and use of swimming pool, taking bath in swimming pool with other children or in the tub is also important. So physical examination of the external genitalia and to exclude other causes of dysuria, sign of inflammation, poor hygiene, and any evidence of discharge should be elicited. Any bruising to the genitalia should raise a suspicion of sexual abuse. Okay, now how you manage this child? So essential investigation when vulvovaginitis is clinically suspected include a urine dipstick and a vaginal swab for culture and sensitivity, as we said earlier. And
Okay.
the possibility of the thrush and threadworm should also be considered. Uh, Genital symptoms are occasionally appointed to child sexual abuse. Management should focus on the following measure.
This is very
Provide,
important, Dr. Tahir.
yeah,
This is very
yeah, this is
important.
very
Management
important.
of
Yeah,
vulvovaginitis, right?
yeah, very important.
This is vulvovaginitis, right? Hmm.
Yes, yes, yes.
This is very
Uh,
important. You have to tell this in the communication. Very
yeah,
important. Just take a screenshot it. So
yeah.
management should focus on. Okay, you read. You read. Yeah,
Okay,
you read. Yeah.
okay. So local hygiene, number first, most important. The second is the avoid bubble bath and scented soaps. That is the soaps with good odor because there is a chemical in that. So a bubble bath means, yeah, bubble bath means that you put detergent in that and make bubbles in the
Detergent.
bath.
Yeah.
Yeah, okay. And use loose fitting cotton underwear, and salt bath may be useful. Specific treatment of the bacterial or fungal infection when identified on low vaginal or perineal swabs. Yeah, if there is any so treat that. Mebendazole therapy when a threadworm infestation is suspected. Treatment is recommended for the whole family and repeated a fortnight later. Piperazine is the recommended drug for infant below 6 months of age.
Yesterday I had a patient of
Yeah.
vulvovaginitis, and I
Hmm.
suspect it is threadworm. So I gave mebendazole
Yeah.
because at night the child has itching,
Yeah.
full night. See, same history they said. Treatment is recommended for the whole family and repeated fortnight later, after 15 days. Piperazine is the recommended drug for infant below 6 months, but more than 6 months, we will give mebendazole. Mebendazole, how much dose? 1
Uh,
TSF BD 3 days. Mebendazole is a atypical drug. 1
mhm.
TSF per oral BD for 3 days. Eradication of threadworm.
Yeah. Yeah. Um, it comes with which name? Maybe Nazul?
See, estrogen
Uh,
cream, Timarin cream applied
yeah.
sparingly to the vulva. Sparingly to the vulva. Mane, you will apply it on the region, not
Yes.
on the
Yes.
vulva.
Yes.
On the
Yes. Yes.
region, local region, relieve the problem in resistant cases because by increasing vaginal resistance to infection, because steroids
Yes.
suppress the area.
Yeah.
So, and concern about sexual abuse should be prompt to a referral of the safeguarding agency or
Yeah.
pediatrician. So, 8 advice. Number 1, cleanliness.
Yeah.
Number 2, avoid scent or bubble bath, but you can use salt.
Hmm.
Then you can use loose fitting cotton underwear, and underwear should be repeatedly changed,
Yeah.
especially for female child. This advice is very important that underwear you should change frequently. Whenever it is, wet after toilet, you should change it. And specific treatment of bacteria or fungal infection when identified on low vaginal swab. So swab is important, okay? And mebendazole or piperacillin, we know, and estrogen cream. So 3 treatment: mebendazole, piperacillin, estrogen cream, or fusidic acid and fungidal cream. So there are many local creams. If you suspect it is
Yeah.
fungus, you should use fungidal cream. If you suspect it is bacteria, you should use topical fusidic acid. If you suspect it is repeated resistant infection, then you should use estrogen. Okay. And concern about sexual abuse, especially if there is a tear in the hymen, like 7 o'clock position, there is an oblique tear in the hymen, and there is a blood inside the vulva, or
Yeah.
there is another thing that is called what, Dr. Tahir? That is the repeated sexual exposure can cause
Yeah.
atrophica vaginalis, something condition.
Yeah.
What is that? Lichen atrophicus. Okay, lichen atrophicus in children is a highly suspicious of sexual abuse.
Yeah. So this slide is very, very much important. This one, like
Mm.
this vagina, it is really important.
It can come in history, it can come in communication.
Yeah.
Okay, finish. Yeah.
Yeah. Okay. So.
Sorry, Dr. Tamanna, regarding the estrogen cream, I think they can change. It's not act as a steroid. It can act as a to increase the acidity of that medium.
Oh,
So that's the reason they become resistant to that. Because
okay. So they will
in
reduce the
teenager,
acidity.
there is no estrogen, so there is no acidity in that area. So they are more prone to infection.
Oh, got
So
it.
that's the reason they
Okay.
are releasing estrogen, applying so that the medium there's the you can so non-functioning glands become active in that area, and they secrete
Mm.
create a acidic medium that is resistance for the bacteria or other infection.
I got it. Yeah, I got it. Okay, very nice points. Yeah. Actually, these topics now we did not read. We do not read. We only read clinical. Like these topics are very neglected topic, but it is very important topic. Okay, now we can
Yeah,
do the
really.
scenario of communication and inshallah history taking.
Okay.
Okay, this is what case, Dr. Tahir. Let us finish this chapter, then we will. Let us finish this chapter, Dr. Tahir. You open that one.
Okay. Again, I'll open that. And this last case we do, and then we can switch
Then we
over to
can do some
communication.
communication. Yeah, history. Yeah.
And sorry, Dr. Tahir, they did not mention about
Yeah, okay.
leukoesterase in UTI
Nah, they are not mentioned.
because
in the nice
leukoesterase and
Sorry.
nitrate both leukoesterase.
Yes.
Is
They
it in the
did not
nice
mention.
guideline? No.
No,
Okay.
they didn't mention. They didn't mention leukocyte esterase. They just mentioned the leukocyte and this one.
Nitric
Because
nitrate.
because the sensitivity and specificity of all the three is 95%. Okay, leukocyte esterase, the WBC, and the nitrite, and that of any two is 70 to 85%. Okay, and nitrite is very much specific. It is more specific than the leukocyte esterase.
Yes, there is. Yeah.
Yeah.
Because we
So
have seen a lot of patients with sterile pyuria. Only WBCs are there, just as we have mentioned already, but there is no nitrates and no leukoesterase. So sometimes it's difficult to decide regarding the future of that patient.
See,
Because we
I
have already started
open.
the medication, antibiotic, and we are not sure if in our just like third world countries, they started antibiotics, they are taking at home already. So sometimes it's very difficult to decide about the antibiotics duration.
Yeah, I'm posting one from the NICE guideline that if the urinary nitrite is negative, that time the leukocyte esterase or WBC is not sufficient enough to prove it is a UTI. Okay, so you have to send the culture again. So urinary WBC, that is pyuria, or leukocyte esterase, they both can happen outside the urinary tract infection like vulvovaginitis. So they say that the management is different. So leukocyte esterase is not so strong evidence. Okay, do not like this. They are saying here that leukocyte, this is from the NICE guideline I took. Okay.
yeah, actually, the weightage of leukocyte esterase is equal to that of the leukocytes. Why? Because it is secreted by the WBC. Yeah. So that's why they both are equal. But when they combine, then the effect is more. Okay, so this is a 9-year-old Matthew presented to the emergency department with a maculopapular rash, and just wait a minute, please. Yeah, sorry, with a maculopapular erythematous and itchy rash after eating a chocolate. Okay, he was treated with oral antihistamines, and the rash subsequently subsided. Other than for mild asthma, he is fit and well. He has no previous history of allergens. Result of the blood tests done are available at the outpatient appointment. So the total IG is high. The specific IG for the hazelnut is also high, and the specific IgE for egg, it is normal. Specific IG for the peanut, it's also a bit high, and that for the milk specific IgE, that is equivocal. You can say that's normal also. So the peanut and the hazelnut, they have and total IG also high. Okay, so what they're asking, I think they might be asking what is the most likely I'm sorry. Yeah, so these are the examiner question. Interpret the result. Yeah, so I think this is a blood. Yeah, Dr. Manna, you can hear me?
We can hear you,
Yeah, okay.
Dr. Khalid.
Okay. So I think the interpretation is that the total IgE is high and the specific IgE for the hazelnut and the peanut is high. Yeah, so yeah, total elevated IgE and the exactly the same thing, elevated total IgE and
Dr.
the
Tahir,
elevated.
book is not there.
It is not visible. Okay, okay. I'm sorry. I thought it's visible. Okay, again. Now,
Yeah.
okay. Yeah. So this was the interpretation of this. The child had a chocolate and he had a rash. Then they gave antihistamine. It subsided. He's also having mild asthma. So otherwise he's fit. So they just did the blood test for him. This is the result of the blood tests. You can see.
Yeah, according to the test, it look like he's allergic to
Yeah.
hazelnut and the peanut.
Yeah, hazelnut and the peanut, exactly. So the same thing they have said that the question number one is that, yeah, he has elevated total IgE and specific to hazelnut and peanut, that these are elevated. Okay, so what further information would be helpful in the management of this condition?
So this child came with anaphylaxis or only rash? We have to
Only
see,
rash.
is it
Only
only
skin
rash?
skin manifestation.
No chlorpheniramine oral syrup only.
Yeah.
For how many
No,
days,
no,
Dr. Tahir?
no, no. The question is not this. The question is, what further information would be helpful in the management? Like the information given to you is that he has asthma and he also has a rash after eating chocolate. So what further information you want?
There are
What
two
is the
things in
question?
this case. How can we
Okay.
proceed, and how can we get information from the family? Is there any family history of nut and peanuts allergy, and is there any precautionary measure they are taking before? And this child, we have to decide. Either we have to label it as means allergy to this one, means, and we have to avoid the peanut and the hazelnut in whole of his life, or either we need bracelet or just like these things. Either we can
Yeah,
proceed or not.
okay. First of all, we have to refer every allergic child. We have to refer to the allergy specialist. Okay, the management will be done by the allergy specialist. This bracelet will be given or not. Chlorpheniramine for the further attack, future attack will be at home, supplied at home. These things actually all will be decided by the allergy specialist. As a GP or suppose as a general pediatrician, our role is to confirm that this is a allergy. Okay, and then we will refer number one and treat for the underlying now
Here,
condition. So I will
sorry,
give.
Dr. Tamanna, here
Yeah,
we
yeah.
need three referral. Three
Okay.
referral. Number one is, as you mentioned. Second thing, allergy nurse, and third is dietitian.
Yeah, yeah, dietitian. Yeah, you are right. Yeah, yeah.
Yeah, but I mean, they are asking that what further information you will take. So the further information is basically a history based. So you will ask about any previous history of contact with allergen and having such symptoms. Then how much time actually it lapses. This is for any suspected allergy history, okay?
Yeah,
So the
yeah,
second
yeah.
important point is the time lapse between contact and development of the symptoms. Then severity of the symptoms, like is there any respiratory problem, is there any choking problem, is there any diarrhea, vomiting, is there any blood pressure low. So you just need to ask about the severity. Then the duration of reaction, in how much time usually it resolve, how much time it starts to happen, how much time is persistent, and then when it become resolved. Then the history of previous reaction and necessary treatment. So only home-based treatment given. How many times it happened? Was there any hospitalization? Was there any need to rush to the emergency? So all this we need to ask. Then the personal atopic history. Just like here in this case, there is asthma, so we need to ask current medication and any drug allergy and any family history of allergy, atopy. So they have almost covered everything. Like family history, they have covered the drug history, they have covered the past history, they have covered the present history. They have elaborated that the severity of symptom, contact with allergen in the past, how much time it start to happen, for how much time it persists. So this is a very good points, I think, for a history taking of a suspected allergy.
Yeah, yeah. Please
Yeah,
let me take the screenshot.
yeah, because never I
Very-
found that
Mhm.
much beautiful in other
We
books.
never come across this type of, this
Yeah,
type of boxes. Actually, this book I like because it has boxes, boxes make you understand clearly everything.
yeah. And then some allergy specific history, like is there any tingling of mouth and lips? Is there any angioedema with swelling of lips or face? Any nausea or vomiting? Any skin rash? Any abdominal pain? A feeling of tightness around the throat? Yeah, I mean that is which area is involved. Then going towards the anaphylaxis things, that is, was there any whistling sound? Was there any breathing difficulty? Was there any swelling around the throat? Any dizziness? Any drowsiness? Or any low blood pressure? Again, the same things, but in different columns they put them. So breathing difficulty, wheeze, any choking or swelling around the throat sensation, or low hypotension, low blood pressure. So these all points towards anaphylaxis. Okay. I think that is a very good slide. Okay, now something to talk about, as Dr. Yasir said, the indication for referral. Uh, so the indication for referral is if there is a faulting growth. Just give me 1 minute, please, Dr. Manna. Just
Good morning. Assalamu alaikum.
Walaikum salam. Assalamu alaikum. I was sleeping.
Yeah, no problem.
Okay. Yalla, continue.
Yeah, so Dr. Tahir and me, we were preparing for this. This is the nice guideline about referring to a allergy child. Okay, how you
Okay.
will refer to a allergy child. So this allergy is very important, you know already. So indication
Yeah,
for
yeah.
specific referral, specialist referral is faltering growth in combination with gastrointestinal syndrome. Suppose any child who has cow's milk protein allergy, suppose, or who has problem with suppose egg allergy, peanut allergy, repeatedly attack. Okay, then you have to refer to the specialist. Normally in any allergy, we refer to the specialist normally, but indication for specialist referral, specific condition, there are specific condition you have to refer
So,
early.
Anna,
urgently.
sorry to disturb you. What is this allergy? This is that like the milk allergy in
Any
chicken
allergy,
or what?
milk,
Any
peanut,
allergy.
any allergy. Yeah.
What are the indications when you refer?
Yeah, referral for
Okay.
allergy specialist.
Okay.
Yeah, referral to
Okay.
allergy specialist. Allergy or pediatric interest on allergy. Okay, very important box. Specialist. So first of all, if any child has suppose vomiting, diarrhea, and the child has faltering growth, suppose the child is not response to a single allergen elimination diet. Tar mane ki, suppose the child has milk allergy, you stopped the cow's milk. Even then, the child is not becoming asymptomatic, still symptomatic. That means the child has multiple allergy, or mother is taking cow's milk allergy, or the child is taking goat milk or other milk that has this allergen. Sometimes, the food allergy, milk allergy, egg allergy, nut allergy, they are combined. If the child has one allergy, he may have another allergy. Like 25% of the cow's milk child has goat milk allergy or camel milk, any milk allergy. Okay. So number one, you should think about that the poor response maybe not, it is not a single food, maybe it is multiple food allergy. History of one or more acute reaction, suppose anaphylaxis. If any child has acute reaction more than one time, you have to refer. History of one or more several days reaction, delayed reaction.
No,
Suppose
sorry, Dr. Tamanna, any anaphylaxis, any anaphylaxis should be referred.
Yeah, should be referred. Yeah. One or more. Yeah, you're right. My question is, Dr. Yasir, that if any child has no anaphylaxis but has food allergy, we will not refer. We will refer, na?
We will refer to dietitian and nurse allergy. We will not refer to the this allergy doctor. We will refer him to the specific, just like cow milk protein allergy. We need a gastroenterologist. He knows. Yeah, he has, just like he has, as you told, he has cow milk allergy. He has goat allergy. Just like there, we need that this domain is not controlled by him, so he needs allergy specialist.
Yalla, what is the need of making things so complicated? Just refer any allergy. This is easy, na? But yeah, you are right that in case of only food allergy, you should refer to the food specialist, that is a gastrointestinal specialist or dietitian or nurse. There is no need of, but if any anaphylaxis, they need intervention, then you have to refer for the allergy doctor. Okay. So if there is a delayed reaction, delayed reaction for more than 4 hours, that's why any child who presented with acute anaphylaxis, you should admit, because mother maybe tell you, doctor, I know, I can give epinephrine, please discharge. But actually you should admit, because it can have delayed reaction, and delayed reaction can, the child can die. So you should admit. Confirm IgE mediated food allergy and concurrent asthma. So any allergy, you should rule out asthma and atopic dermatitis. And significant atopic eczema, that is atopic dermatitis or eczema, where multiple or cross-reactive food allergy are suspected, okay, by the parent or by the carer. If any child has gluten allergy, suppose he may have other rye, barley, this allergy. So like this. Persisting parental suspicion of a food allergy, especially if the child is young with difficult or perplexing symptom despite a lack of supporting history. So persisting parental suspicion of food allergy, means if the parents suppose that there must be some allergy, but there is no such evidence. But if the parents are suspecting, okay, then you should just wait.
Yeah, I can read. So I think for indication for the specialist referral, I think we should not we should remember the 3 or 4 which are very important. That is, if there is any growth failure with persistent GI symptom, number first, that is very important. The second one, if even after elimination diet, because the first line therapy of the food allergy is eliminating diet, but still, even if after eliminating diet there are persistent symptoms, so this is another indication. Third, if there is any anaphylaxis. Fourth, if there is so parental anxiety, if the parents have they are thinking that no, the child is not improving, so this is also one of the indication for referral. Okay, and if there is a strong suspicion of IgE mediated food allergy, so these 4 or 5, these are very specific and they are written everywhere. Because the IgE mediated allergy, it will less likely to be healed. Okay, so I think, Dr. Mana, if we have some time, because now it's a prayer time almost over here, Friday. So we can do today later on this history
after
of food
prayer,
allergy history.
Yeah, you can.
Okay, so I'll prepare that.
Yeah. Dr. Yasir, if you are free, we can read some history or some other communication. Dr. Tahir will join after prayer or after lunch.
Yeah, still I have some time. Let's finish this topic at least.
Yeah.
Okay, so what advice should be given to the family? So the first step, it is important to clarify with the family that advice was given at the time of presentation and understand whether the pediatric team saw this patient with presence of the reaction. The result of the blood test should be shared with the family and the risk of future reaction discussed. The fact that severity of the future reaction cannot be predicted should be emphasized. As such, the need to set in place measures to manage this at appointment is necessary. The presence of asthma is an important consideration regarding management. The consult in charge of the patient should speak to and counsel Matthew and his parents, giving them information about the anaphylaxis, information about the risk of biphasic reaction, information on what to do if anaphylaxis occurs, if the child has not previously been prescribed with EpiPen. So just tell them how to use the EpiPen. If wheezy, give salbutamol, and stay with the child. Role of antihistamines if there is allergic reaction, and avoid any trigger, and BLS training programs, and information for the need of referral to the allergy specialist. Does the child require an EpiPen prescription in this case? So in this case, an EpiPen is not indicated. The possible indication of the requirement in case of children suspected nut allergy would include signs of anaphylaxis in a previous reaction. But in this case, he has no respiratory or cardiovascular symptom. So reaction to minute amount of allergen, like reacting after being touching by someone who has handled nuts. Coexisting asthma requires inhaled steroids, and living in remote area with no access to immediate medical facilities or ambulance services. So they are also one of the indication to prescribe them the EpiPen.
Okay, so Dr. Tahir, summarize please what you understood, EpiPen.
Yeah, so what I understood that when you should prescribe EpiPen, in which condition. So if there is a past history of anaphylaxis, or if there is now you found that there are signs of anaphylaxis, and if there is the patient is living in a very remote area, in which case he has no access to the medical facility quickly, so in that case also you need to give them this EpiPen. These are 2 or 3 very important indications to write EpiPen.
So 3 indication, right? Signs of anaphylaxis now, suspicion of anaphylaxis in the future, and if the child has asthma, taking steroid. 3 suspicion of then we will give anaphylaxis.
Yeah, exactly.
Okay, Dr. Tahir, I think